Before we begin, if you struggle to remember high-yield medical concepts, I've created a clean medicine mnemonic pack that turns topics like this into fast, exam-ready memory tools. Link is in the description below. The core problem in Down syndrome starts at the level of the genome. The cells carry an extra copy of chromosome 21. That means extra gene expression, especially genes involved in brain development, cardiac structure, and amyloid production. That genomic overdose is what produces the characteristic face, intellectual disability, congenital heart disease, leukemia risk, and early Alzheimer's disease. Remember the mechanism clearly. Trisomy 21 leads to excess gene dosage, which leads to multisystem abnormalities. How does this happen? In most cases, it is meiotic non-disjunction, usually of maternal origin, and the risk increases with maternal age. Less commonly, a Robertsonian translocation involving chromosome 21 is present. Rarely, mosaicism occurs and the phenotype is milder. For exams, the key association is advanced maternal age with non-disjunction. Now let's translate genetics into clinical findings. Think head-to-toe pattern recognition. A newborn or child may have a flat facial profile, epicanthal folds, upslanting palpebral fissures, small ears, a protruding tongue, a single transverse palmar crease, hypotonia, and an increased gap between the first and second toes. In the eyes, look for Brushfield spots, which are speckled white or gray spots on the iris margin. Cognitive impairment is present and ranges from mild to severe. Down syndrome is not just a facial pattern, it is a comorbidity syndrome. Associations include atrioventricular septal defects and other endocardial cushion defects, duodenal atresia, Hirschsprung disease, atlantoaxial instability at C1 to C2, acute lymphoblastic leukemia, and early-onset Alzheimer's disease. Why early Alzheimer's disease? Chromosome 21 carries the amyloid precursor protein gene. With an extra chromosome, there is extra amyloid production, causing earlier accumulation of beta amyloid plaques and early dementia. That is a classic exam mechanism. Diagnosis at birth is usually clinical, but laboratory confirmation is genetic testing. A karyotype establishes trisomy 21, translocation, or mosaicism. Prenatal diagnosis is also done. Chorionic villus sampling is done at about 10 to 12 weeks and allows early diagnosis but has higher fetal risk. Amniocentesis is done at 15 weeks or later with lower risk. Both are especially discussed in mothers older than 35 or with abnormal screening tests. Increased nuchal translucency, decreased PAPPA, elevated beta-HCG, and decreased alpha-fetoprotein are classic early findings. Management focuses on surveillance, early intervention, and treating complications because there is no cure for the chromosomal abnormality itself. Cardiac evaluation with echocardiography is essential. Thyroid function should be checked yearly. Hearing testing is done every 6 to 12 months. Ophthalmologic exams are needed early in life. Cervical spine evaluation is important before sports or anesthesia due to risk of atlantoaxial instability. Treat associated disorders such as Hirschsprung disease, duodenal atresia, congenital heart defects, leukemia, and thyroid dysfunction. Developmental, speech, and educational support significantly improve functional outcomes. Here's the core exam sentence to lock in. Trisomy 21 causes intellectual disability, characteristic facial features, atrioventricular septal defects, duodenal atresia, Hirschsprung disease, increased risk of acute lymphoblastic leukemia, early-onset Alzheimer's disease, and atlantoaxial instability. If you understand the cause-to-effect chain, not just the list, you are already ahead of most students. This is the Why Medic. Subscribe for more high-yield topics.